Good afternoon, class. Today, we will be diving into the fascinating topic of calcium homeostasis. Calcium is crucial for various physiological functions, including nerve conduction, muscle contraction, and bone formation. In order to maintain the delicate balance of calcium in the body, a complex interplay of hormonal regulation and feedback mechanisms takes place. In this script, we will explore the regulation, pathophysiology, clinical manifestations, diagnosis, monitoring, and management of both hypercalcemia and hypocalcemia. Calcium homeostasis is primarily regulated by the parathyroid hormone, PTH, calcitonin, and vitamin D. PTH is secreted by the parathyroid glands in response to low serum calcium levels. It acts on the bones, kidneys, and intestines to increase calcium levels. Calcitonin, produced by the parafollicular cells of the thyroid gland, counteracts the effects of PTH and promotes calcium deposition in the bones. Vitamin D, on the other hand, enhances calcium absorption in the intestines. Hypercalcemia refers to elevated serum calcium levels above the normal range. This condition can arise from various causes, such as primary hyperparathyroidism, malignancies, vitamin D intoxication, or granulomatous diseases. In primary hyperparathyroidism, excessive production of PTH leads to increased bone resorption and intestinal calcium absorption. Malignancies, particularly those affecting the bones, can release calcium into the bloodstream. Vitamin D intoxication can result from excessive vitamin D supplementation, leading to enhanced intestinal absorption of calcium. Hypocalcemia, on the other hand, refers to decreased serum calcium levels below the normal range. It can occur due to various etiologies, including hypoparathyroidism, inadequate vitamin D production, chronic kidney disease, or malabsorption syndromes. In hypoparathyroidism, insufficient PTH levels lead to decreased calcium absorption, increased renal excretion, and impaired bone remodeling. Inadequate vitamin D production can result from insufficient sunlight exposure or impaired liver or kidney function. In patients with hypercalcemia, a multitude of clinical manifestations can occur. These encompass various symptoms such as fatigue, weakness, constipation, polyuria, and the formation of kidney stones. In more severe cases, individuals may exhibit altered mental status, muscle weakness, cardiac arrhythmias, and in extreme instances, even slip into a coma. It is important to note that hypercalcemia can also contribute to the development of osteoporosis, inflict damage to the kidneys, and induce a condition known as calciphylaxis. To diagnose hypercalcemia, serum calcium levels are measured along with other laboratory tests, including intact PTH, vitamin D levels, and markers of bone turnover. Imaging studies such as bone scans or computed tomography, CT, scans may be necessary to identify the underlying cause. In terms of monitoring, serial measurements of serum calcium levels and regular renal function tests are essential in assessing treatment efficacy and detecting potential complications. The management of hypercalcemia involves addressing the underlying cause and symptomatic management. In cases of primary hyperparathyroidism, surgical removal of the affected parathyroid gland may be recommended. For hypercalcemia associated with malignancies, treatment typically involves chemotherapy, radiation therapy, or bisphosphonates to reduce bone resorption. In severe cases, intravenous fluids, loop diuretics, and calcitonin may be utilized to enhance calcium excretion and lower serum levels. In the management of hypocalcemia, the primary goal is to restore normal calcium levels and address the underlying causes. One essential aspect is the administration of calcium and vitamin D supplements, especially in patients with hypoparathyroidism or vitamin D deficiency. It is also crucial to consider dietary calcium intake, as well as reducing phosphate levels and managing other associated electrolyte imbalances. These measures are integral to achieving optimal management and ensuring the overall well-being of patients with hypocalcemia. Hypocalcemia can lead to a wide array of clinical manifestations. These can include neuromuscular irritability, such as paresthesias, muscle cramps, tetany, and seizures. Cardiovascular manifestations, including prolonged QT interval, arrhythmias, and heart failure, may also arise. Furthermore, hypocalcemia can impact bone health and increase the risk of fractures. Furthermore, malabsorption syndromes such as celiac disease or gastric bypass surgery can result in reduced intestinal absorption of calcium. Hypomagnesemia, frequently seen in alcoholics or those with malnutrition, can also impair PTH secretion and exacerbate hypocalcemia. Other causes include medications such as diuretics or antiepileptics, which can interfere with calcium homeostasis. Signs and symptoms of hypocalcemia can vary depending on the severity and rate of onset. They may include neuromuscular irritability such as tetany, muscle cramps, or paresthesias. Patients may also experience cardiac manifestations like prolonged QT interval, which can lead to arrhythmias. Moreover, severe cases may present with seizures or even laryngeal spasm, which can be life-threatening. In conclusion, the pathophysiology of hypocalcemia involves various mechanisms including reduced PTH production, malabsorption, impaired vitamin D activation, and electrolyte imbalances. Prompt diagnosis and appropriate treatment are essential in managing this condition to prevent potentially serious complications. Patients with hypocalcemia may experience a wide range of symptoms, including numbness, tingling, muscle cramps, and spasms. Fostic's and Trousseau's signs may be present as clinical manifestations of neuromuscular irritability. Severe hypocalcemia can lead to tetany, seizures, and life-threatening arrhythmias. In children, hypocalcemia can interfere with the development of dentition and skeletal abnormalities. Diagnosing hypocalcemia involves measuring serum calcium levels, along with simultaneous assessments of PTH, vitamin D, magnesium, and albumin. Electrocardiogram, ECG, findings may provide additional evidence of hypocalcemia. In terms of monitoring, regular measurement of serum calcium levels, renal function, and electrolytes can help evaluate response to treatment and identify potential complications. The management of hypocalcemia centers around repleting calcium levels and addressing underlying etiologies. In acute symptomatic cases, intravenous calcium gluconate or calcium chloride may be administered to rapidly correct calcium levels. Long-term management typically involves oral calcium supplements, vitamin D therapy, and close monitoring of serum calcium levels. In conclusion, understanding calcium homeostasis is crucial in assessing and managing both hypercalcemia and hypocalcemia. By comprehending the regulation, pathophysiology, clinical manifestations, diagnosis, and management of these conditions, healthcare professionals can provide optimal care to patients. Remember, calcium balance is fundamental for maintaining numerous bodily functions, and it is our duty as future healthcare providers to ensure the proper management of these imbalances. Thank you for your attention, and I encourage you to delve further into this fascinating field of endocrinology.